So I think the video is still on. Okay, so I'll just introduce a few of our, there's going to be three panelists, including myself. The first panelist I want to introduce is actually my mentor and my boss as well, Professor Poncho Birowo. He's the Faculty Staff Department of Urology, Cipto Mangunkusumo Hospital in Indonesia. He's a former advisor to the Global Andrology Forum and one of the founding fathers of Indonesian Society of Andrological Urology. He specializes in andrology, endourology, and renal transplant. And he's currently working at Cipto Mangunkusumo Hospital, Bunda Hospital, and also Siloam Asri Hospital. The second panelist is Dr. Juvido Agatep. How are you, Dr. Juvido? He's currently the head of Department of Urology in Providence Hospital. He subspecializes in minimal invasive urology, robotic assisted, and retroperitoneoscopic, laparoscopic urology, tumor surgery, renal transplantation surgery, and minimal invasive donor nephrectomy. He went for a few fellowships in various hospitals, including Beijing, in Changgung Hospital, Erasmus Medical Center, Children's Hospital in Boston, and Harvard University. He's currently is working at the East Avenue Medical Center, St. Luke's Medical Center, and Global City and Malvar Hospital. How are you all the panelists? Oh, and I have to introduce myself as well. My name is Diandra. I work in Universitas Indonesia Hospital, and I'm currently the co-coordinator for this year's AURC session. Professor Poncho, Dr. Juvito, are we ready?
Yes, on my part,
Okay.
Nadra,
Okay, thank you. Thank you, Dr. Juvito. So, Professor Poncho I think he's with us as well. Okay.
Yes.
So we're going to have three topics for today's discussion. The first one is going to be started by Dr. Matthew Knobs, sorry, from Australia. And he will present his presentation. You have 10 minutes, and then we're going to have another 10 minutes of discussion. Please, Dr. Matthew.
All right. I'll just see if I can share my screen. Yes, well, thank you very much for that. Thank you for giving me the opportunity to present this afternoon. And I'm going to present a case of a management strategy of a testicular mass in an azoospermic man seeking fertility. But as you've said, I'm currently working in Australia from New Zealand and working on the Gold Coast at the moment. So my case to discuss is a 35-year-old man who presented with his partner with primary infertility that had an inability to conceive after greater than 12 months of trying with unprotected intercourse. He'd had no prior children, nor had his partner. He had no prior testicular or scrotal surgery. In particular, he had normally descended testes as a child. He was otherwise a fit and healthy man, no medical background, no regular medications. On physical examination, the most notable abnormal finding was actually bilateral hypotrophic testes that on initial examination we estimated about 10 cc's both sides, equivalent on both sides. He had some normal findings. In particular, no palpable mass was detected. He had normal secondary sexual characteristics. There was no suggestion of hypogonadism. His BMI was normal. Gynecomastia was absent, and vasa were palpable on both sides. In terms of investigations which were initially undertaken for assessment of his infertility, his semen analysis on two separate occasions demonstrated azoospermia with volumes of 2 mils. Both of his gonadotrophins were elevated, consistent with a non-obstructive azoospermia. A few other normal findings to comment on. He had a normal karyotype, so he wasn't a Klinefelter's. His testosterone was just inside the normal range, but once he actually accounted for his sexual binding globulin, his free testosterone was marginally low. And as will be important later, all of his tumor markers were normal. As part of his assessment, we did perform an ultrasound. This was actually mainly to assess for potential obstructive causes for his infertility. And incidentally, without any clinical suggestion of finding this, we found a 7mm vascularized hypoechoic solid lesion within the right testis. There was no surrounding microlithiasis, and the ultrasound confirmed our clinical findings of small testes on both sides. So overall, we reached the diagnosis of a clinically impalpable lesion within an atrophic testis in an azoospermic patient. Now, given his background of infertility, our primary concern was a germ cell tumor. So the clinical issue we faced in terms of management decision-making is addressing the competing priorities of dealing with the oncological management of this testicular tumor while preserving his fertility management and his endocrine function. So the management options we discussed with this patient was observation of the testicular mass alongside spermatozoa harvest, be that with a microtesty or a tessie. Alternatively, treating the testicular lesion on its grounds and concern for germ cell tumor with an orchidectomy alongside an ex vivo harvest of the spermatozoa, so-called oncotessie, and the potential role of a partial orchidectomy in this patient as well was discussed. Based on some departmental discussions, we recommended an orchidectomy with an oncotessie, but the patient declined at this stage, citing his personal concerns for resulting hypogonadism, and he requested an interval imaging. We undertook that 4 weeks later. An ultrasound again demonstrated similar changes with some possible growth. This time the maximum measurement was 8mm, but this is also potentially attributable to inter-observer variability. At this stage, we discussed this case at a urology MDM, and the consensus again was to treat the lesion on its own merits and use the orchidectomy as an opportunity to gain spermatozoa for his fertility pursuits. So he did proceed on this occasion to an inguinal orchidectomy. He had an off-table bivalving of his testis. An embryologist was actually on site, and we're able to provide them with some viable spermatozoa. So we had that confirmation about 4 hours after the testis was removed. They have been cryopreserved at the time of presenting today. I haven't had confirmation that they've been used for artificial reproduction at this stage. The pathology of the testis, however, demonstrated not a germ cell tumor, but a Leydig cell tumor. There were benign histological features, nothing to suggest malignancy. There was some surrounding atrophic seminiferous tubules, but throughout the parenchyma of the testis, we also saw Leydig cell hyperplasia. He otherwise made an unremarkable postoperative recovery. He has no clinical features to suggest ongoing hypogonadism, but we don't have biochemical reassessment of that at this stage. So in conclusion, the competing interests of managing testicular mass in an azoospermic man can be safely managed using usual practice of both of these, and actually provides a good opportunity for sperm extraction simultaneously. Interesting point I thought about this case is that Leydig cell tumors are documented to be a potential cause of infertility, but they would present this as a pre-testicular azoospermia with a low gonadotrophins rather than high. And it's worth noting that in similar cases, removal of these Leydig cell tumors have not led to approval in the semen parameters. This tumor was seen on the background of Leydig cell hyperplasia, and this is presumably in response to serum high gonadotrophins. But reading similar cases, there's no evidence that this is truly the case. So thank you very much for the opportunity to present, and that's the end of my case.
Okay, thank you, Dr. Matt, for your great presentation. I noticed there's a few points that we definitely can discuss. I mean, there's always an interesting point when somebody had testicular tumor or cancer, is still worrying about his fertility. So I bet it's going to be a good discussion. Probably I'll give the floor first to Professor Poncho. Do you have any questions, Prof?
Yeah, thank you very much, Dr. Diandra. Congratulations, Dr. Adnobs. I still have as a presentation, I have still question. Is there any information about the left testicle in ultrasound or something? So the patient is incidentally found tumor during the ultrasound examination, right?
Correct, yes. So the lesion was on the right side. The left testicle was small. I think from memory it was about 7 cubic centimeters, but no lesion was seen on the left side.
But the patient present with the azoospermia.
Correct.
So means that the left side, left testicle also there is a problem in the left testicle, right? If he's there's no problem, he will produce sperm during the ejaculation. Yeah, we can find sperm in ejaculation. So how old is the his partner?
His partner is mid-30s as well. He's 35. They're of similar age. I think she's about 36.
Are they going to, I mean, to have a baby in the short time, or they are still only for the preservation?
No, they're wanting it done in a short period of time. This is a relatively recent case. Their management was initially done by gynecology and came through to us on identification of the testicular lesion. So we've taken his follow-up on, but I haven't had any clinical management of their fertility beyond meeting her in the consult room alongside him.
Yeah, maybe if they know that there is a tumor in the patient, maybe they want to postpone the plan to have baby. And now the sperm is already in the they already freeze the sperm, right?
Correct.
Yeah. Okay, I think the most important, if we also inform the patient what is the percentage of the successful rate if we do the IVF here. Because if I assume that if there's a problem also in the left side and we already taken all in the right side, the only chance that we have is only from the freeze sperm, right?
Correct, unless we proceeded with a micro TC on the contralateral side or a TC, you know. But yes, that is where we are currently hanging our hopes. You're quite right.
I think it's an interesting case. That's all from Dr. Diandra.
I think,
yeah.
Oh, sorry.
Yeah, go ahead, Dr.
I was just going to say, in hindsight, when we found out it was a Leydig cell tumor, or a benign tumor, we sort of thought, oh, well, there was a missed opportunity to do a partial orchidectomy and have testicular sparing surgery. The sort of dots that we connected early in the case is infertility and a testicular mass, and that's increased risk of germ cell tumor in that combination. But fortunately, we had counseled the patient about a benign entity, and so he's happy enough with the outcome at this stage.
Okay, Dr. Juvito.
Yeah.
Hi. Do you have any comments or questions, probably?
Yeah, I think this is actually a straightforward on-call infertility. It's a case of on-call infertility. And my first question is, when you will start a gonadotropic therapies, what should a clinician should do or should say to his patients, before you will implement gonadotropic therapies? What are the consideration that you will inform the patient?
So I think in this case, if we were going to start exogenous testosterone, we'd need to notify them about the impact on fertility of that, in so much that it would make them essentially infertile beyond what their current infertility parameters already demonstrate. There would be alternative roles for, I don't have any clinical experience of it, but aware of HCG in this case of providing gonadotrophins while preserving fertility.
Mhm.
Was that answering the question?
Yeah. So how about sperm banking?
Well, he's always been azoospermic, and so at no stage we had ejaculatory semen or spermatozoa.
But in case these patients have sperm in their ejaculate, then probably you can also inform these patients to have.
Yes, sorry.
Yeah, okay. But of course, oncotese is an option on this patient. Okay.
Yeah.
So, when do you advise your patient to have semen analysis after the cessation of the gonadotropic therapy? When do you advise your patient when these patients underwent therapy?
I must confess, I'd be guessing and basing it on sort of first principles, but I know the life cycle of a spermatozoa takes about 86 days, so it'd be at least that, and you'd probably need time for it'd depend on the nature of the testosterone supplementation, but hypothetically it'd be about 3 to 6 months following cessation of testosterone supplementation.
Okay, but on some articles it's around 12 to 24 months. Okay.
Okay, well, yeah.
And last questions: if this couple should when this couple should avoid contraception for at least how many months after chemotherapy or radiation? How do you advise these patients if they go to chemo? The male will undergo chemotherapy because
Yes.
okay. So when do you advise this patient couples?
I must have confessed I wouldn't have a clear answer for this either, but I would assume, again, testicular function would take quite a significant amount of time post chemotherapy to normalize, and I'd again guess at about 12 months.
Yeah, I agree with you. At least 12 months. Okay, congratulations. Okay, these are all my questions.
Okay, thank you, Dr. Jovido. Probably I have a few questions regarding the case. What was the status of his spermatozoa after the TC? I mean, is it still viable? How what's the status of it? How much the motility and everything?
Yeah, sorry, I wouldn't be able to give you exact numbers, but the feedback that we had from the embryologist was that they are viable of reasonable numbers, because we gave them a big chunk of seminiferous tubules, and then they sort of took that away and put it all under the microscope. And it sounds like they've got everything, enough that they wanted. But I couldn't give you a percentage of motile or normal morphology.
Okay. For to be honest, I've never done a partial orchiectomy before. Probably Professor Poncho and then Dr. Jovido has some experience regarding it, because one of the treatment option you mentioned before was partial, and then especially when now that the histopathology is Leydig tumor, and you would proceed with the partial. Any comments on that, Professor Poncho or Dr. Jovido? Probably Professor Poncho first, if you have it.
Um, I haven't case. I haven't have kind of this case before, but if the patient have the normal testicle in the left side, maybe we will go to the radical orchidectomy. But in this case, the patient, or we can say that the only testicle that they have that is quite quote unquote is normal is the right side. So the partial orchidectomies become of one of the choice, as long as we can have a very close observation. If the patient is have can do the routine checkup for ultrasound or another another lab test, we can do the partial orchidectomy.
Probably one addition to it is we should perform like a frozen section intraoperatively to know the margins as well, right? Right,
Yes,
Professor?
correct.
Okay. Dr. Jovito, probably you have any experience regarding partial?
Yeah. Actually, I don't have any experience about partial orchidectomy, but I have a patient who had also a testicular tumor. Then I advise this patient to because he has a normal contralateral testis, and I advise this patient to have a sperm banking. No, so this patient actually underwent orchidectomy on the side where the tumor is, and this patient also subject is himself for sperm banking, and I think sperm banking can have at least an, uh, an ART, no, paternity rates of around 48 to 82%. Yeah? And you can actually freeze that sperm for a decade, and in papers at least 28 years is the longest reported in for live birds. Okay?
Yeah.
So for me, I don't have that partial orchidectomy patient.
Okay. Okay, thank you. Due to the time constraints, I'm sorry we can't discuss any further, but very interesting case, Dr. Matthew. I thank you for sharing it with us, and hopefully we can meet in Bali soon next month.
I look forward to it.
Congratulations.
Thank you so much, guys.
Thank you. So we'll move
Thank
on
you,
with
man.
the second presenter, Dr. Bun Moisor from Cambodia, and we'll be talking about varicocele, which is, I bet that's one of the most common findings in male infertility. So Dr. Bun Moisor, please, the time is yours.
Thank you, Professor. Good afternoon, Professor and Doctor. My name is Bun Wisawa. I'm from CUA, Cambodia Urological Association, and today I have the great honor to present the case presentation of male infertility. And my topic is about primary male infertility case presentation related varicocele. Okay. For the patient information, he is 28 years old and he worked as a teacher in high school. And for the medical and retail history, he has no smoking and he used alcohol occasionally, and he has no diabetes, hypertension, and he has no history of surgical, traumatic, or infectious or genital urinary tract. And for the family history, he has no family history of infertility. And for his couple or his partner, his wife is 24 years old with normal gynecological examination and fertility. And for the clinical manifestation, he comes to the OPD present with minimal dullness pain in his left testis during the cold weather or long standing, and it starts for 6 months. And moreover, he complained severely about the infertility of 2 years, that he tried to have baby with his wife, but unsuccessfully with the regular antibiotic. And then we have done the physical examination. For the general appearance, he looked fit, healthy, with normal BMI. And for the external genital examination, we have found the specific finding for his penis. It looked normal, no phimosis, hypospadial. And for his both testes, we measure it in normal size and good consistent, but we found that it has the significant capable of left dilated line that we feel like a backbone in less testis, and we consider as the varicocele grade 2. And then for the investigation, we have done the standard blood test with SSH, and the result in normal range. And for the imaging, we have done the flotal ultrasonography and found that it has the dilated left testicular venous plexus with the volume of both testicular in normal range, and the diameter of the venous plexus more than 3 millimeters. And for his semen analysis, it showed the oligospermia with the sperm concentration 14 million per minute, and astenospermia with only 26% of progressive motile sperm, and for the sperm morphology in normal range, 4%. And for this clinical manifestation and investigation, we consider him as the primary male infertility associated with less symptomatic varicocele grade 2. And for our treatment plan, we have two choices. Firstly, percutaneous embolization treatment, and second is surgical repair. But unfortunately, percutaneous embolization treatment needs the advanced and experienced radio interventionalist to perform it. And actually, in our hospital, we don't have this performance or technical funding, and we can't do this procedure. So we choose the surgical repair for this patient that use the open less subinguinal varicocelectomy. That is the procedure with less complication and recurrent of operation. And for the follow-up, we have follow-up the patient in 6 weeks for the clinical evaluation, and he come with normal appearance, and we look for the wound is in good healing, and for his symptom, he released dullness or discomfort on the left testis, and the examination of internal genitalia is normal. And then we have follow up in 3 months for the semen analysis, and the result is a major rate that show that the improvement of sperm count. It has 16 million per milliliter, and the volume of progressive mobility also improved to 54%. And around 1 year after the operation, he and his wife really happy with the good result that they got the spontaneous pregnancy when they meet us at the outpatient department. So for conclusion, I want to remark that the cause of male infertility should be identified to get a better treatment and prognosis for the patient paternity. And also, varicocele is also the curable human cause of male infertility that found that in 15% of the total male population and in 40% of male infertility. Although the mechanism of alteration of sperm parameter is not well understood, but surgical treatment of clinical varicocele is improving the sperm concentration, mobility, and morphology for the patient. That's all for my presentation. I would like to say thank you for your attention. Thank you.
Thank you, Dr. Boon, for your presentation. I think this is also a very interesting case because we will meet them a lot in our clinics, especially when you're doing andrology. Dr. Jubido, probably you can start if there's any questions or comments you want to give, please.
I just want to verify, did you requested for endocrinologic testing, FSH, LA?
Dr. Boon?
Could you ask the question again,
Did
Professor?
you request
Not
for
clear.
endocrinologic testing? Endocrinopathy testing like FSH, LH?
For this,
There's total testosterone?
we have not done this hormone evaluation. We just done the FSS evaluation because in our country, this measurement is limited, and we can do the assessment of hormone, sexual hormone for the patient.
Yeah, because in patients with infertility, there are 3% of infertile male having underlying endocrinopathology. That's why I am asking if you have requested for this. Of course, except you have already a finding of varicocele, no? Which could be the reason why this patient is infertile, no? But there are a subset of patients also that needs evaluation of the endocrinology, no? So patients that has total testosterone level of less than 300 nanogram per deciliter actually needs also to undergo this testing. Okay, so that's why I'm asking you if you have done the total testosterone, serum testosterone. No? Then actually, what should be, no, the other conditions that you will also request for endocrinologic testing includes an abnormal semen analysis of less than 10 million per millimeter concentration, and if this patient has also ejaculatory dysfunction or ED. No? So if these patients, if you ask from your patients about this history, you might also probably inform this patient to undergo this testing. Thank you.
Thank you, Dr. Javido, for very insightful points there. I think that's one of the important things to consider as well, especially in patients with infertility. One of which is the blood evaluations, endocrinological evaluations are very critical for us to diagnose and move forward to the next appropriate treatment. Professor Poncho, probably you have any comments or questions.
Thank you, Dr. Diana. Congratulations to Dr. Boon. If I'm not mistaken, that the wife is 21 years old, right?
Yes, the wife is 21 years.
How long did the patient have been married?
They got married for 2 years.
2 years, okay.
Yes.
So during the marriage, they didn't have any child, right? There is no pregnancy also, right?
Yes.
Yep.
Of course.
how many times do you consider doing the sperm analysis? Because the abnormality is quite light. The number of the sperm is 14 millions. Yeah, the morphology is normal, but the motility is only slightly less. How many times do you usually want to repeat the semen analysis?
Normally, we have to do the semen analysis with interval of 3 months to repeat the semen analysis. But for this patient, he used to do the semen analysis 1 year ago, and the result is not good too.
Okay.
And he come to with us at OPD. At the time, we have only done one time for semen analysis. Yes.
Are you also considering to do the DNA fragmentation index assessment in this patient?
For this patient, we have not done the DNA fragmentation because uh, they just got the infertility, and he has never got the pregnancy with miscarriage or abortion repeatedly. So we know that to do it.
Are you also considering to give like medicamentation before the operation or after the operation?
After the operation, we just give the pain relief medication and advise him the lifestyle change, also like exercise and don't drink the alcohol. Yes. Because this patient he used alcohol occasionally.
Okay. Are you also give some vitamins, antioxidants, or something like that? No.
Yes, no.
Okay, thank you, Dr. Diana.
Okay, thank you, Professor Poncho. Probably from my side, Dr. Boon, it's just an addition from from my humble opinion. Probably for patients with infertility, don't forget to put their sperm analysis result, whether they're oligospermic or even azoospermic, to the diagnosis, because it's going to change whether you have a varicocele with oligoasteno probably, and severe OAT or azoospermia. It's going to be difference in the treatment. So I think if you want to put if you have a patient who's infertile due to varicocele, for example, please put in the sperm analysis result as well, so that it's easier for you or other doctor to know the whole story of the patient. That's just probably one of my humble opinions. There's a question here from the Q&A from the participant regarding the technical aspect of ultrasound. The Dr. Lusaya asked, is the measurement must be on a upright position? And do you have any tips and tricks of actually doing the ultrasound? Probably I'll start with Professor Poncho, because I know you do some of your ultrasounds yourself. Probably you can give us your tips and tricks, Professor.
Yes, for the scrotal ultrasound, we have to do in two positions. So firstly, we do in the long the upright position, and also it is at repose position. Yes. Reachable position also apply for the ultrasound, scrotal ultrasound for evaluate the varicocele. And sometimes we can ask the patient to do the Vazava maneuver, and we do the ultrasound. Yes, simultaneously.
Okay, thank you. Did you mean falsafa maneuver? Was it, Dr. Boon?
The Vazava maneuver is the maneuver that we increase the abdominal pressure, and yes, we can see clear the varicocele when we examine or we do the ultrasound for the patient.
Okay. Thank you. Professor Poncho, probably do you have any tips and tricks
Yeah,
about
maybe just some kind of tips and tricks that we are doing the ultrasound examination and scrotal examination. If we do by ourselves as a urologist, make sure that the room is quite good. I mean, there is not too many people. Sometimes in the clinic, sometimes there's no privacy when we are doing the ultrasound. So we have to make sure that the privacy, and then we can put towel below the testicle to make sure that the testicle is in the supine position, that the testicle is not too low from his body. And then, as the Dr. Boon said, that we can do the first is without the what we call it. Sorry, yang without Doppler, and then we do the doctor examination. Yeah, we should have the doctor examination during the examination of the testicle, especially if we want to see whether the varicocele or not. Yeah, thank you.
Okay, thank you, Prof. Poncho. Dr. Jovido, probably
Yeah.
do you do your own ultrasounds?
Yeah. I sometimes I do my ultrasound, no. But I agree with Dr. Boon, no, that the most important aspect of identifying your varicocele is during uh, in upright position, and ask your patient to do Valsalva and do your ultrasound. And the most important thing is to if you will note more than 3 millimeter of that dilated vein, so that you will be able to tell that this patient has varicocele. Okay, then of course, for grade 2 and grade 1 and grade 2, it's really needed to have ultrasound evaluation. But for grade 3, which means that your varicoceles are already clinically evident on physical examination, then probably ultrasound is not any more needed for grade 3 varicoceles. Thank you.
Okay. Yeah, thank you, Dr. Jovido. Probably this is the last question from Dr. Lusaya as well. If the patient has a contralateral side varicocele without any probably any, this is my addition question, without any symptom, would you regard to do a bilateral varicocelectomy, Dr. Boon? Or what about this patient?
Thank you for your question. This is good question. For the contralateral subclinical varicocele, mostly we just do the homolateral varicocele with clinical symptom, grade 2 or grade 3, but for subclinical we just don't do it. So we just do the varicocele repair, unilateral, not bilateral. And as I see at the opinion or at the study of the hospital, I also see they just do unilateral OC too for the varicocele with subclinical contralateral, like the case you asked us. Yes, thank you.
Okay, thank you. Dr. Jovido, what do you usually do in patients with subclinical contralateral varicocele, if the patient is infertile, of course?
For infertile, but it's subclinical. I'll still do the first. I'll still do an ultrasound. If the ultrasound says that there's varicocele, then I will do bilateral varicocelectomy.
Okay, what about you, Professor Poncho?
Yeah, I agree with Dr. Fido that if there is bilateral, although it's subclinical, but we found varicocele during the ultrasound examination, then I will do the bilateral operation.
Okay. Okay, thank you, Dr. Boon, for your presentation. Due to the limited amount of time, we have to finish our presentation. Thank you very much. Congratulations, and hope we can see you live in Bali. Bye. Take care.
Congratulations, Dr. Boon. Congratulations.
Thank you, Professor.
Congratulations, Dr. Boon.
Okay, for the last but not least, our presentation about male infertility for today will be it's a bit hard of a case because it's dealing with idiopathic infertility. It's going to be presented by Dr. Sat Norin from Cambodia as well. Dr. Sat, the time and place is yours.
Thank you very much for your coordination for the event. So now let me share my slide. Sorry.
I think we still can't see your slide, Dr. Sat.
Wait. Sorry. I'm working on it. Sorry.
Okay.
Do you see my slide now?
Yeah. Okay. Please full screen it first before you start. Yeah.
Yeah.
Okay. Go ahead.
Do you hear me well?
Yes, we hear you,
Yes.
Crystal.
Yes, thank you very much. Good afternoon, all professor, and so my name is Sanodan. I'm from Cambodia, Urology Association. Today it's my pleasure to be able to present my case, which is about male infertility case presentation. First of all, for patient information, the patient with the age of 35, uh, he is healthy, fit, no smoking, alcohol, occasionally, no diabetes, no hypertension, and no history of surgery before. And patient presentation, he has no symptom at all, and he just want a baby. He got married for 1 year, and he has unprotected sexual intercourse with his wife, which is has a normal menstruation regularly. And for the initial evaluation, he is healthy, fit, with normal BMI, and he works very hard with his stressful job as an engineer. And on history taking and physical examination, he has normal partner life, enjoys sexual intercourse regularly, and he has normal ejaculation. On physical examination, all in normal range, including his testis size, penile gland, urethra, no meatus, has no hypospadias, no penile angulation. And the test that we conduct, we do blood test and semen analysis. And for the semen analysis, unremarkable. Here, I show you, which is in France. Like, and here we has volume of the semen, pH, bit alkaline, and normal viscosity and other things are normal. And his spermatozoa are like 32 million per milliliter, and all are normal with vitality. And for the sperm progressive motility is like 60%. And we diagnosed him with idiopathic male infertility. And for the diagnosis criteria, like I have shown in the semen analysis. For the treatment plan, we do the stress. We advise him for stress reduction, exercise, alcohol cessation, and vitamin E supplementation. And for the patient outcome, in 3 months, he came back and tell us about the good result with satisfaction, and he got a baby. And for the discussion, idiopathic male infertility affect around 30% of cases. Empiric treatment, including gonadotropin, aromatase inhibitor, and antioxidant. For all antioxidant, for treatment of idiopathic infertility, carnitine, which is amino acid, and vitamin E appear to have more benefit for treating male infertility. However, there is a lack of light well designed trial with clinical importance and point for antioxidant efficacy. And take away key point to success. The key to success in managing the patient is to know what is the his complaint and knowing exactly the patient expectation in order to fulfill the patient need. And thank you for your attention.
Okay.
That's all of my presentation.
Okay, thank you, Dr. Noren, for your presentation. I think this is one of the most difficult male infertility case that we can find. That is worth, I think, to discuss, to broaden our knowledge more about this area. Okay, for the first comments and question, probably I can give to Professor Poncho, whether you have any comments about
So
this.
I have some clarification first, but so the semen analysis is normal, right?
Yes, it's normal.
But is there any, are you did also the DNA fragmentation index?
And then, can you ask? Okay.
Did you check also the DNA fragmentation index test?
No, in Cambodia we don't have that kind of test. And honestly, for this case, I take it from the assisted reproductive team, which is managing by OB-GYN.
OBG.
And in Cambodia, most of all of the infertility is covered by the OB-GYN. And for this patient partner, she is 25, and he has been checked up with the OB-GYN and unremarkable result.
So did you also do the ultrasound examination in this patient?
No, I don't do the ultrasound examination. The examination, his testis size seem to be normal, so I don't think it is necessary.
Yes, since the quality of the semen or the semen analysis normal, maybe ultrasound we can consider not to do it. Yeah. It seems that this patient is the idiopathic male infertility. Yeah, maybe after we give some this empiric treatment, maybe we can also the patient also have a high stress in this in his job.
Yes.
Yes.
Yeah.
Maybe we can also discuss with the patient, give some kind of what we call it, some kind insight, not to have a heavy stress on doing it. I know. Is there any erectile dysfunction problem in this patient?
No. All in good condition.
In
For
good
the patient, he has a very stressful job, and for his infertility, it makes more stress, like accumulation of the stress.
The problem is are they doing the sexual intercourse in the routine time, or because of the heavy load of the working makes the frequency of the sexual intercourse is reduced? Is there any reduction of the sexual intercourse in this patient?
Yes, sometimes we ask him about the sexual time. Sometimes it's like a skip because he's work very hard and physically and mentally tired sometimes.
Yeah. Yeah, maybe the problems. Yeah, so we know that the problem of the male infertility can be pre-testicular, testicular, and post-testicular. In this case, maybe we have to assess the possibility of the post-testicular problems, such as the sexual intercourse problems in this patient. Since we know that the semen quality is quite good in this patient. So although we give the empiric treatment, the another treatment, vitamins and antioxidants and others, if the sexual intercourse is not in the good way, maybe they still have difficulty in achieving a child. But thank you.
Yes.
Congratulations, Dr. Sat. This is very nice case. Then, and usually we will find this case a lot in our clinical practice daily. Yeah. Thank you.
Thank you, sir.
Thank you, Professor Poncho. Dr. Juvido, do you have any?
Yes, this is a very interesting case because this is most of the time that we see in our clinics. No, so we don't know how to deal with these patients every time that they come to us. But anyway, modification of lifestyle is the most important here for idiopathic infertility. No, so if you tell me that this patient has a very stressful activity, very stressful lifestyle, then probably this patient has, of course, lack of sleep. Okay, so this is the most important thing that you have to also to ask from your patient, because lack of sleep per day may affect the daily GnRH output from the hypothalamus and your pituitary, and this may probably some causes the infertility problem. No? So again, stress can increase cortisol, that also affects the HPT axis. No, so these are the important things that you have to discuss to your patient, and they have to modify, or he must modify his lifestyle. No, aside of course from the comment a while ago regarding the post testicular, which is the sexual function. No, so this is also very important, asking a sexual function of these patients, because if this patient has sexual dysfunction like loss of libido or ED, you might also consider doing total testosterone evaluation, and probably this may also help you to proceed with your evaluation, or probably more tests that you can do, such as requesting for FSH, LH, if this patient has a low testosterone level. No? So again, check the dietary of this patient, because there are some processed foods that will affect the hormonal profile or the case of endocrine dysfunctions. And what are these foods? Such as you should advise this patient to avoid soya, tofu, which increases the estrogen level of this patient, and this can also give this patient a problem with this idiopathic infertility. So I think this is more of, for me, it's a more of modification of lifestyle. Thank you very much.
Okay.
Thank you, sir.
Thank you. Thank you, Dr. Javido. I think, yeah, andrology, I think, is one of the fields in urology where you have to have a good connection, you have to spare time for your patient, because you have to know a lot of things. That is usually, the patient probably consider it not that important, but we have to find out in order for you to, for us to know the main problem of the patient, and moving on forward with the treatment. Probably it's different with onco or stone patients, where you can just, you know, see the ultrasound CT scan, and then you can notify them directly that there's a stone or there's a cancer. It's probably not that long of a discussion. With andrology, it's I bet Dr. Javido and this is, I'm quoting Professor Poncho actually. He always told us that you have to spend time more with your patient who is infertile, especially patients with idiopathic. You know, when they see the results, everything is normal, and on the other hand, they still have a problem conceiving, which is it's a headache sometimes for both the patient and the urologist as well. Okay, there's a question from the Q&A about screening the patient for subclinical infection, the genital tract subclinical infection. Do you usually do that, Dr. Jovido and Prof. Poncho?
Can I go first?
Yeah, Dr. Jovido, please. Yeah.
Yeah, most of the time I also include screening of these patients because this patient might have also a history of STI, STD, and prostatitis that may affect also the, of course, the sperm transfer. No, so sometimes they have these patients. The result of the STI on the vas deferens. So I ask also history on or evaluation of infection.
Okay, Professor Poncho.
Yeah, thank you for the question, Dr. Dennis Lusaya. I think we can, if everything is normal, then we have to search another possible of male infertility. So Maggie or male accessory gland infections can be possible in the unexplained of male infertility. But usually I will see the concentration of leukocyte in the sperm in the semen analysis. If it is high or normal but almost high, maybe I will ask for the semen culture to see whether there is a bacteria or not in the semen. That's my answer. Thank you.
Okay, thank you, Professor Poncho. Another probably a one more minute to discuss about giving idiopathic infertility patient antioxidants. What do you usually give, and how long do you usually give them for before evaluating for another semen analysis or another evaluation afterwards? Professor Poncho, probably you can start.
Yeah, antioxidants we can find a lot. Yeah, the brand is very a lot, but we have to explain to the patient that they have to wait at least 3 months. Yeah, I will say so 3 months, and then we wait 3 until 6 or 9 months to make to mention that this the treatment is succeed or not, or we have to change with another thing. If we already give the empiric treatment and then still there is no improvement or there is no pregnancy, then we have to consider to do the IUI or IVF in this patient.
Okay, thank you. Probably last few words, Dr. Javido, before we close.
Yeah, I agree with Dr. Roncho regarding the antioxidant. No, that you have to inform this patient that these are only supplements. No, so there's no guarantee. So then probably if it will not work, then we will do the IEC.
Okay. Okay, thank you very much, Dr. Satnorin, for your presentation. Hopefully we can see you in Bali. Thank you and congratulations. I would like to say thank you for our panelists today as well, Professor Poncho Birowo and Dr. Jovido Agate, for your valuable time and insights about male infertility. After this, we're going to have another session regarding renal cancer. But before I hand the moderator off to Dr. Wayan, we have a wheel of fortune, of a sort of speak. The lucky ones will get what will they get, Professor Poncho? A Tesla, was it? Or
BYD? No. They will get a tumbler. They can
okay.
get the tumbler in Bali.
Yeah.
They are
So whoever got pick of this wheel, you can get your tumbler during registration on site in Bali. Please. I think we will stop in 3, 2, 1. Yes, please stop. And we'll see who's going to win the tumbler. Dr. Arif Ristia Pangestu, is he here? Please raise your hand if you're here. Otherwise, we will do the wheel. We'll reshuffle again. Please, are you able to chat or raise your hand? Just notify us if you're present in this discussion. Okay, I think Dr. Arif is not here. Probably we can do that, do the spin again one more time. Hopefully. Oh, Professor Poncho raises his hand.
No, I'm not raising it.
Dr. Firtantio Adi Syahputra. Dr. Firtantio, are you here? Oh, unfortunately, Dr. Firtantio is not here. I see the attendance list. Okay, last but not least, probably the third time's the charm. We can redo the shuffle again, and then we see who's the winner. Dr. Idewa Gede Reza, are you here or not? Probably we can confirm from committee, is he here or not? Otherwise, we can shuffle again. Dr. Missy, yeah, I think we can shuffle again. Last time probably because of time, we will shuffle again, and then if the lucky one is not here, probably we can notify them directly. Dr. Nobunori Shota, are you here?
Yeah, supposed to be. He is also the person to lead the
Oh
second
yeah,
topic.
you're going to present the next session, Dr. Shota. Okay, congratulations. Please get your tumbler during the registration when you arrived in Bali, Dr. Shota. Okay, with that, I will give the moderator to Dr. Wayan for him to continue on with our second session. I would like to thank everybody here, Professor Poncho, Dr. Juvido, for your time. And also, we see from the participant, there's about 86 participants currently joining. Hopefully, we can learn something about male infertility, and we can help our patients more in the future. Okay, thank you everybody for our time. Dr. Wayan, the time and place is yours.
Okay, thank you, Dr. Diandra, Prof. Poncho, and Dr. Jufido. Good evening and good afternoon, everyone. Okay, we continues this pre-event webinar for the second session. The second session with topic management of complex renal tumor. Okay, in this session, there are the three panelists and three presenter. Let me introduce first for the panelists. First panelist, Dr. Kurnia Penta Saputra, PhD. Dr. Kurnia is a senior consultant of oncology urology. Dr. Kurnia now is medical staff in Department of Urology, Dr. Saiful Anwar Hospital Malang, and currently he head of the urologic residency program at the Faculty of Medicine, Brawijaya University. The second panelist, Dr. Thomas Yuhenshu from the Taiwan Urologic Association. Dr. Thomas is a senior consultant of the uro-oncology, and he specializes also in the endourology, robotic, and laparoscopic surgeon. Dr. Thomas currently appointed as chairman in the urologic division at the Taipei City Hospital, and chairman in the Department of Surgery in Taipei City Hospital, renal branch. And third panelist, myself, Wayan Yudiana, from the urologic department, Professor Ngurah, General Hospital, Udayana University. Also, we have three presenter, and each of presenter will be cases about the complex renal cell carcinoma. Okay, for the set time, first, the presenter Sota Nobumori. Okay, congratulations for Dr. Sota for the winner of Tumbler. Dr. Sota will be presented about the case of metastatic renal cell carcinoma treated with pembrolizumab and lenvatinib combination therapy previously and followed by the cytoreductive nephrectomy. Dr. Sota, time is yours.
Thank you. Can you see my slide?
Yeah.
Okay. I am Shota Nobumori from JUA, presenting in the section complex renal tumor. I present a case of metastatic renal cell carcinoma treated with pembrolizumab plus lenvatinib combination therapy, followed by cytoreductive nephrectomy. First of all, let me introduce myself. I currently live in Ehime Prefecture in Japan. I am in my third year of urology. Let me turn to the case presentation. The presented case was a 73-year-old man. His main complaint was intermittent gross hematuria. He had been aware of the symptoms for several months.
Sorry,
Can you
slide
show,
slow?
Dr. Sota?
Sorry.
Because your slide is not moving to
Okay,
the
please
next slide.
slide show your presentation.
Slide.
Okay, slide slow. Slide show your presentation because your presentation not moving.
Not moving.
Yeah.
Dr. Shota, don't worry about it. Just share your screen and don't use the slideshow. Just go to slide one by one. It will help.
A slide.
It's okay. Yeah.
Oh, okay.
Yeah, it's okay. Okay.
Sorry. His main complaint was intermittent gross hematuria. He had been aware of the symptoms for several months and visited his local physician. He was referred to our hospital for further investigations and treatment because an abdominal echocardiogram showed a left renal mass. His medical history includes hypertension since the age of 55. No other pre-existing medical conditions. Oral medications were amlodipine and olmesartan for hypertension. In terms of the physical examination, we felt that he had no abdominal findings of note. In addition, performance status is also considered to be 100%. This slide, I use the animation, so I want to use slideshow mode. Sorry. Sorry. There were no significant abnormalities in the blood test. The inspection items included in the IMD series classification are presented. Contrast enhanced CT showed a finding in the left kidney that were highly suspicious for 9.6 clear cell renal cell carcinoma. In addition, the test suggested multiple lung metastases and the possibility of liver and adrenal metastases. An MRI was performed to further investigate suspected liver and left adrenal metastases. Liver metastases were negative, but left adrenal metastases were suspected. We subsequently performed left renal tumor biopsy for definitive diagnosis purposes. The pathology results showed grade 2 renal cell carcinoma. Based on these laboratory findings, we diagnosed left clear cell renal cell carcinoma, multiple lung metastases, and left adrenal metastases. TNM classification is clinical T3A N0 M1. And DIMD series classification is intermediate. After starting pembrolizumab and lenvatinib combination therapy and confirming its efficacy, we decided to consider deferred site reductive nephrectomy. Sorry, I used this slide in animation. The combination therapy was started with pembrolizumab with 200 milligram every 3 weeks and lenvatinib 20 milligram per day. Grade 2 hypertension was observed and antihypertensive medication was adjusted. The patient also developed grade 3 fatigue attributed to lenvatinib, and the dose was reduced to 40 milligram per day. In addition, hand-foot syndrome and anorexia were observed. After approximately 3 months of treatment, the patient was found to have partial response on imaging. CN was considered possible, and left balloon was performed approximately 4 months after the start of treatment. The peritoneum was incised at the lateral descending column. The gelatinous fascia was incised and the descending column was passive. Thrust window was created and dissection was advanced to the renal portal. The renal vein was identified and the gonadal vein was cut with vessel sealer. And the renal vein was skewered. And the lumbar vein was cut with vessel sealer. The renal artery was skewered and hemorrhaged. The renal vein was blocked with hemorrhages and cut. The renal artery was subsequently blocked with hemorrhages and cut. The central adrenal vein was cut with a vessel sealer. The perinephric area was dissected so that the adrenal gland could be removed. The ureter was also blocked with hemorrhages and dissected. The perineal area was dissected circumferentially. The pathology showed slight residual viable cells in the kidney, but no viable cells in the left adrenal gland. As there was a small residual lung metastasis, the combination therapy was restarted 1 month after surgery with the aim of achieving CR. I reported a case of complex renal tumor treated with pembrolizumab plus lenvatinib combination therapy followed by site-related nephrectomy. The combination therapy has been reported to be superior in reducing tumor size. We believe that this case confirms the efficacy of the combination therapy and balloon can be performed safely. And that concludes the presentation. Thank you very much.
Okay, thank you very much, Dr. Sota, for your nice presentation and step-by-step management of metastatic renal cell carcinoma. So we have 10 minutes time for the Q&A and any comment from the panelists. Okay, for the first opportunity, I give to the Dr. Thomas. Hi, Dr. Thomas, how are you?
It's good. Not to meet
Okay.
everyone.
Okay, sorry, I forgetting Dr. Thomas will be Taiwan local organizing chairman for the UAA Congress 2025 next year. Please, Dr. Thomas, is there any question or comment from you?
Okay, congratulations to Dr. Shuri about the excellent presentation and also a very, very rare case. I have a question that since you are going to do cytoreductive nephrectomy, now why you try to use a vessel loop to loop the renal vein first? Is it possible to control the renal vein directly with Hemolux or endo-GIA? So it might be more time saving or more efficient to do the robotic cytoreductive nephrectomy. This is the first question. The second question is, does this patient still receive the pembrolizumab and the lenvatinib combination therapy till now, or it just stopped all the treatment?
Sorry, could you repeat your first questions more slowly?
Okay, the first question is, since we are going to do a cytoreductive radical nephrectomy, then why you use vessel loop to loop your renal vein first? Is it possible to control the renal vein directly using endo-GIA, the vascular stapler, or Hemolux? So it might be more time saving for the whole operation. You use a blue vessel loop to control renal vein first. Then you use Hemolux to control the renal vein and cut it, right?
Yeah.
Yes.
Yes. So why you try to use vessel loop? Is it possible to control the renal vein first directly using GIA? Because back to the surgical principle, we usually control renal artery first, followed by control the renal vein. But today you control renal vein first, then control the renal artery. Can you explain why?
I'm sorry, I'm afraid I don't know the answer to your first question. Sorry.
Okay.
Okay.
Dr. Sota, why you first ligation the renal vein first, not renal artery first?
You apply the Hemolux on the vein first, not the artery first. Why? Or I proceed the demonstration. Why you cut the vein first before the artery? Usually if we do the laparoscopy nephrectomy, usually we cut the artery first, but you did the vein first. Why?
Take it easy. Don't worry about it. Just take it easy. And
Okay, maybe proceed with the second question, Dr. Thomas.
okay, let's go to the second question. Is the patient still receive the pembrolizumab and the lenvatinib combination therapy till now, or he has stopped all the treatment now?
We decide to continue with combination therapy because we found a small number of viable cell tumors in the kidney, and consider we plan to continue this combination therapy for 1 year after surgery, taking into amazing findings and adverse symptoms.
Okay, thank you. Thank you.
Sorry.
Okay. That's enough, Dr. Thomas?
Yes.
That's
No,
enough?
it's enough. It's enough.
Okay.
Thank you.
Okay, thank you very much, Dr. Thomas. Now I give opportunity for the second panelist, Dr. Penta, please.
Thank you, Dr. Wayan. Congratulations, Dr. Sota, for your nice presentation. I have a question about why you choosing the combination pembrolizumab and lenvatinib rather than the other combination, because there are some combination pembrolizumab with axitinib and so on. Why you should choose the combination with lenvatinib?
Thank you for your question. We choose this pembrolizumab plus lenvatinib combination therapy because the patient had gross hematuria, and because of the potential for tumor shrinking.
Okay, you say that the result of the treatment is the partial response, but you don't show us about the result of the CT after the treatment. You say that the partial response, but you don't show us the result of the CT after the treatment. Is there any CT scan after the treatment?
Yes. Sorry.
Okay, you understand, Dr. Sota? Dr. Penta question, what the parameter you use to definitive the after the treatment you say this is the partial response. What the parameter, like diameter or
the size of
yes, the diameter. Yes.
Is there any reduction of the tumor diameter maybe?
No.
Okay. Okay, Doctor, Wayan?
Yeah.
Please.
That's
from me. You can
okay,
go on.
thank you, Dr. Penta. Okay, Dr. Sota, I have one question. What the technique of the renal biopsy you use in these cases? What the technique of renal biopsy?
We performed renal biopsy to definitive prognosis.
Yeah, what the technique?
What
the open biopsy, core biopsy, systematic biopsy, or targeting biopsy?
Targeting biopsy.
What the guidance?
We use echocardiogram.
Echo.
Yes.
Okay. Okay, maybe Dr. Thomas, any question again or any comment for this case?
For me. It's enough from me.
Okay, just the sharing experience in the Taiwan, how to manage or how the incident and manage for the metastatic renal tumor is any more?
In Taiwan, for metastatic renal cell carcinoma, currently we have two choices. Some surgeons will do radical nephrectomy first, followed by the combination therapy. But there is a trend that we are going to use the immunotherapy, including pembrolizumab with lenvatinib and some immunotherapy combination first, followed by cytoreductive radical nephrectomy. This is why I asked Dr. Shota about the rationale for control the renal pedicle. Because sometimes when you try to control a renal pedicle, there might be a lot of adhesion in between. So for safety, some people will try to use the so-called en-bloc control of renal pedicle, including artery and the vein together. But if you try to control the renal vein first, you need to prevent the possibility of possible kidney induration or possible bleeding after you control the renal vein. So this is why I ask you this question. Okay.
Okay, thank you for your comment and advice, Dr. Thomas. We continues the presentation with the second cases, renal cell carcinoma with tumor thrombus in inferior vena cava extending into the right atrium. Okay, these cases will be presented by the Dr. Qaudri Hamza Sarwar from the Pakistan Association of Urological Surgeons. Okay, Dr. Qaudri, time is yours.
Dr. Yudiana will proceed with the third presenter first while waiting for Dr. Chaudhry Hamza to join us.
Oh, so we continue with the third presenter, yeah, Dr. Messi?
That's correct, yes.
Okay, Dr. Uma Giliage Dinendra Madhusanka, okay, right, from the Sri Lanka. Okay, Dr. Dinendra will be presented about the renal cell carcinoma in cross-ectopic pelvic kidney. Okay, Dr. Dinendra, time is yours for your presentation.
Thank you, sir, and good day to all the participants. And I'm Dinendra Madhushankar from Department of Urology, Colombo South Teaching Hospital from Sri Lanka. I am representing Sri Lankan Association of Urological Surgeons. I'm like to discuss about an interesting surgical case, the patient with renal cell carcinoma in crossed ectopic pelvic kidney. A patient is 54-year-old male who is previously healthy, unevaluated patient, worked as a policeman coming from Colombo, and he presented to emergency department with a history of gross hematuria and low abdominal pain for 1 day. Digging into his history, this was the first presentation of gross hematuria, which was painless, and hematuria persisted throughout the stream. There was no clots and no associated lower tract symptoms or dysuria. And he complained associated lower abdominal pain and abdominal fullness. And he doesn't give any metastatic features. And he doesn't have any family history of non-renal malignancies. He's not a patient with metabolic diseases, diabetes, dyslipidemia, and hypertension. No significant drug history, especially antiplatelets or anticoagulants. Examination, he is a stable patient, not pale, with pulse rate of 80, blood pressure of 130 by 80. And abdominal examination doesn't show any loin masses, except he had a tender pelvic mass with right-sided deviation. Other digital rectal examination and genital examination was unremarkable. His basic laboratory investigations was hemoglobin of 12, INR of 1.2, serum creatinine normal 0.9, UFR showed only red cells with urine culture of negative culture. And we opted him for imaging with ultrasonography, and it shows normal right side kidney, and left kidney was absent, and there was crossed ectopic pelvic kidney with a mass with suspicious of malignancy. And he further evaluated with CT intravenous urogram along with chest, and it showed that there was a heterogeneously enhancing 6 by 5 centimeter lesion involving a renal pelvis, suggestive of a renal cell carcinoma in the ectopic pelvic kidney. And right side kidney was normal, and the lower pole of the right kidney is abutting this ectopic kidney without fusion, and the right side ureter abuts the renal cell carcinoma. And there was no lymph nodes or metastasis into lung, liver, or bone. So the diagnosis of a renal cell carcinoma of T3N0 M0 in a crossed ectopic pelvic kidney was made without no metastasis, and he is needed a radical nephrectomy. And here we face several challenges, as it is a malignancy arising from a crossed ectopic kidney. So the treatment plan was, we arranged a multidisciplinary team approach, including genitourinary surgeon, radiologist, vascular surgeon, oncologist, and the pathologist. And the decision was made for open radical nephrectomy of the crossed ectopic kidney with the involvement of the vascular team, and planned to perform surgery under midline laparotomy. And pre-op imaging was assessed, especially the angiogram, to assess the aberrant vascular pedicle and any aberrant vessel involvement of the lesion. And we plan for intraoperative right side stenting to prevent right side ureteric injury. And we adhere to AURC to have a good, smooth post-op recovery of the patient. Bit of intraoperative details. Surgery was performed using midline laparotomy, and we found the tumor which is covered with bowel, and cecum was mobilized medially, and identification of the right side ureter was done because we have stented already, and the ureter was preserved, and the kidney, ectopic kidney, was mobilized using energy device, the ligature, and then the aberrant vascular pedicle was identified. Surprisingly, there was 2 renal arteries arising from the bifurcation of the aorta, and the other one coming from cranial to the bifurcation of the aorta. There was 1 renal vein which drains cranially at the level of L2, L3 level. And surgery was performed and radical nephrectomy was done. It took about 3 hours with a 300 ml of blood loss, and patient was sent to ICU for post-op care, and in about 4 days of hospital stay, he was discharged uneventfully. Patient again reviewed in the clinic with a histology. It came as clear cell renal cell carcinoma of PT3N0 MX, Fermin grade of 1, and the Lebow score of 4 shows intermediate risk and no post-operative complications. So we use the EUA guideline for the follow-up of the patient. As his intermediate risk of recurrence, we plan to do CT on 6 month, 12 month, 24 and 36 month in intervals. And we are waiting for the first 6 month CT of this patient. So as conclusion, the incidence of ectopic kidneys is like 1 in 1,200. And although they are ectopic kidneys, the occurrence of renal cell carcinoma is still similar to as normal native kidneys. And their presentation and the diagnosis is a bit of difficult because of the vague symptoms and difficult presentations. And as well as the surgery, nephrectomy is also challenging because of the aberrant position of the kidney and because of the abnormal vascular pedicles and the close proximity to the native kidneys and the other ureter and the structures. So careful pre-op imaging assessment with multidisciplinary team approach is mandatory to cure and have a good surgical outcome. These are our references, EUA guidelines, and thank you very much for kind listening.
Okay, thank you very much, Dr. Diandra, for the presentation about the rare cases about the renal carcinoma in the ectopic pelvic kidney. Okay, we continues 10 minutes toward for the comment and question. And the first opportunity I give for the Dr. Pentra. Please, Dr. Pentra.
Thank you, Dr. Vidiana. First of all, congratulations for Dr. Dinendra for your nice presentation. I have 2 questions. The first one is why you didn't use the laparoscopy approach for this case? Because I think it's maybe I don't say that simple one, but I think we can do the laparoscopy. And the second one is you say that the patient on the right kidney, you put the stent. Yeah. why you put the stent, not just the ureter catheter, just because the main of the stent is just only for the guiding that there is the ureter for the right kidney. Yes.
Yes.
Okay. I think it's just only put the ureter catheter. I think not the stent.
Yes, let me answer the first question first. In the MDT meeting, we got the decision of whether open surgery or laparoscopic surgery. We do perform laparoscopic radical nephrectomy, but as this case is ectopic kidney with aberrant vascular pedicle, we thought of doing an open surgery would be safer because we are more familiar with it. So that's the reason. And the surgical wise, the oncological outcome is similar both in open versus laparoscopy, but there are no researches against these ectopic kidneys. So we perform open surgery over the laparoscopic surgery. Second, the stenting, if the patient had any urethral injury or any inadvertent injury, stent would be much easier to manage rather than ureteric catheter, which we need to remove just after post-operative period. So we put a stent because it is more practically easier, and for that we can keep for about a few days. Sometimes some injuries might present later. The ischemic injuries, strictures might present later. So we want to keep the stent for at least 1 to 2 weeks.
Okay, because on your presentation there are no the angiography of the ectopic kidney. So
yes, sir. So for that,
so
because we had this console imaging assessments, we don't have the images, so I didn't had the chance to get the images at first.
Okay. Thank you, Dr. Yudiana.
Okay. Thank you, Dr. Penta. Please, Dr. Thomas, if you any question and comment for these cases.
Okay, thank you, Chair. Thank you, Dr. Yudiana. My question is still the same with Dr. Santura. What I want to know is why you don't do laparoscopy. This is my initial idea. Since the location and the tumor, I think it will be perfectly to do laparoscopy. And also you have pre-op angiography, and so it will be easier to find the vessels of the ectopic kidney. But back to in Taiwan, although we have a very big series about laparoscopic nephrectomy, maybe in this case, in the future, if you have another one, since the incident is 1 out of 1,200, so you may consider to use the so-called hand-assisted laparoscopic radical nephrectomy. Use your hand inside the patient's body with hand-assisted device. Then you can achieve both the advantage of open surgery and the minimally invasiveness of laparoscopic surgery. This is my comments. Thank you. Very good presentations.
Yes, thank you.
Thank you, Dr. Thomas. Okay, Dr. Dinendra, I have the question. Maybe this is the global question about the renal cell carcinoma. Okay, how about the incidence of renal cell carcinoma in your country? Is the what the most incident, the urogenital cancer, and then for the renal cell carcinoma specifically, which one the most incident, local renal cell carcinoma or metastatic? Thank you.
So in our Sri Lankan setup, the commonest urogenital malignancies are the urothelial carcinoma, or that the lower urinary tract carcinomas, bladder tumors, and renal cell carcinoma. We don't have local consensus, but from Asian consensus wise, the occurrence is fairly less, and out of them, renal clear cell carcinoma is the one we are having commonly. And now, because of the imaging modalities, we do have a lot of localized tumors now rather than metastatic tumor of renal cell carcinoma. So basically, we deal with majority of localized renal cell carcinoma, majority are clear cell carcinomas. And percentage-wise, we don't have actual consensus because in our country-wise, we don't have.
Okay. There is a question from the audience, Nugraha Gunanmanta. Is there any special strategy to extract of the kidney tumor out of the abdomen regarding the ectopic position?
So, in view of laparoscopic surgery, are they preferring?
Yeah, both of open and laparoscopic.
If it is open surgery, we are performing under, we use the midline laparotomy. And so we just mobilize the bowel so we can directly approach to the tumor, and we resect the tumor out and take out. But if we plan to do laparoscopic, still fenestrial incision would be cosmetical as well as easy approach to extract the tumor out.
Okay. Thank you. Is any comment again from the our panelists, Dr. Penta, Dr. Thomas?
There is still a time to ask. If the patient have a metastatic condition after maybe 1 year, what will you do on this patient? I mean, in the Sri Lanka, yeah. Is there any targeting therapy for this patient in Sri Lanka?
So what type of metastasis? Where we got the metastasis?
Yeah.
So can you repeat the question again? So I didn't get the question.
If after 1 year,
Yes.
the patient get the metastatic maybe on the lung, what will you do for this patient?
So then we again reassess the patient in view of surgical fitness as well as fitness for any adjuvant treatment. Then we refer the patient to oncologist, and we do have this immune therapies are there. We can use pembrolizumab's immune therapy for the metastatic disease. And same time, we see whether the metastasis, there are no consensus, but if it is like oligometastasis, we see whether there's any chance of resectable, whether we can resect the lesion as well.
Okay, thank you.
Okay. How about the lymph nodes dissection during the nephrectomy? You usually perform that or not?
So usually we don't perform lymph node dissection. If the imaging was showing, or if the intraoperative findingly we saw lymph nodes, we do lymph node dissection. Otherwise, routine lymph node dissection we don't do because that doesn't prove any oncological outcome. It's only for staging purpose only.
Okay. How about Dr. Thomas in Taiwan? The standard of care for the kidney tumor when we do the radical nephrectomy, we routinely perform the lymphadenectomy or not?
It depends on cases and also the surgeon preference. For the guideline in Taiwan, we did not routinely perform lymph node dissection for those requiring radical nephrectomy, both laparoscopically or open or robotically.
Okay, if the positive lymph node, or N positive, are you give the systemic treatment maybe?
In Taiwan, if we find enlarged lymph node before operation, we will do lymph node dissection. And also for those with positive lymph node status after operation, and the so-called lymph node metastasis, we will do adjuvant chemotherapy. We will do adjuvant therapy. The first, we try to use the sunitinib as our first-line treatment for those cases for clear cell renal cell carcinoma.
Okay, thank you for your sharing experience, Dr. Thomas.
Thank you.
Okay. For unfortunately, this session maybe the second presenter, Dr. Hamza, is not join with us because there are sudden information. His grandfather is passed away, so we give him opportunity to present his cases for the next week. Okay, because only the second presentation in this session, and this session was finished done. I back the MC to the Dr. Diandra. Maybe Dr. Diandra still here?
Yes, yes, Dr. Royan, I'm still here. My deepest condolences to Dr. Hamza and his family. We just learned about the news about a few minutes ago, so we decided to cut short the session, and then we will commence the session for renal cancer probably next week, before the last session, which is on renal transplant. Dr.
Okay.
Royan.
Maybe Dr. Thomas, can you join us next week for the only one presentation?
It's okay, no problem. Family is always the most important one.
Okay, before before the session of renal transplant, maybe
What time, Dr. Yudiana?
1 p.m. Jakarta time, yeah. 1.
No problem. I will be on time.
Okay. Okay, thank you, Dr. Thomas. Okay, thank you, Dr. Penta.
Thank you, Dr. Thomas. Thank you, Dr. Yudiana, Dr. Diandra.
Thank you, Dr. Penta and Dr.
Thank you,
Thomas.
everyone.
Okay, probably we will have another wheel of fortune, giving out yet another tumbler for this session. So next week we're gonna have one tumbler as well for the renal transplant. So make sure you're available and you're online and you're paying attention to the session so that you're able to win your tumbler. Okay, probably we can start. Okay, stop. Who's going to win? Hopefully, I don't think my name is on there. So, Dr. Derry? Dr. Derry Hafa, are you here? If you're here, please raise your hand, or you can let us know in the chat box. If not, probably the committee can see as well if Dr. Derry is here. Okay. He's not, so we will commence. We'll continue on with the wheel here. Okay. Dr. Sabrina. Is Dr. Sabrina here? Dr. Sabrina Rai Aquino. Are you here? If you're here, please raise your hand.
She or he is here. But
Okay.
yeah.
Okay. Congratulations, Dr. Sabrina, for winning the tumbler. Please get your tumbler at the registration booth in Bali anytime anytime you prefer. Okay, with that, I think we're finished for today's 2 sessions. Unfortunately, it is cut short due to the grief news from Dr. Hamza. So we send our deepest condolences to him. Hopefully everything's okay and we can meet again next week with him presenting and one presenter, one topic about renal cancer before we move on to the next session, which is the last session about renal transplant. Okay, so with that, I thank everybody who's joining, giving their time, and we've been learning together. Thank you, Dr. Wayan, Dr. Thomas, and also Dr. Penta for joining us and leading this very interesting discussion. So hopefully we will see you all next week at the same time. Take care. Have a great day. Have a great week ahead. We will see you definitely in Bali next month. Bye.
Thank you, Dr. Diandra. Thank you for the audience. Welcoming to the Bali in maybe 3 weeks later, in 1st September.
Thank you, Dr. Wayan. See you.
Thank you. See you.
Join us at UAA 2024 in this exclusive location, where world-class facilities meet tropical paradise. Experience the perfect balance of scientific excellence and relaxation. We invite you to be part of this remarkable event. The Bali Nusa Dua Convention Center showcases Bali's prominence as a preferred destination for international events. Situated in the exclusive Nusa Dua complex, it is surrounded by renowned international hotels, providing convenience and comfort to our attendees.
But UAA 2024 is not just about the scientific programs. We have also put great emphasis on crafting a spectacular social programs. Our aim is to make this conference to be one of the most memorable events in the history of UAE.
I urge all prospective participants to visit the conference website to learn more about the program, secure your spot, and submit your valuable scientific contributions. Together, let us make UAE 2024 a resounding success, a platform for knowledge exchange, and a catalyst for advancing the field of urology. We eagerly await your presence in Bali, where science, natural wonders, and cultural delight harmoniously intertwine. Join us for UAE 2024 and be part of this extraordinary journey.
Feel a cozy atmosphere and enjoy the beautiful sunset of Bali. Cheers!
Mari gaya, dating sa Bali. Sawadikap, indi dituan rapun su Bali.
Konying tachelai tau, pali tau.
Namaste. Akshabi logo sa Bali, Nishwagat hei.
Annyeonghaseyo, Bali usin geosal, Annyeong samida.
Ohayo minasang, Bari yokoso minasang.
Om Swastiastu. Welcome to UAE 2024 Bali. Innovation, transformation, transformation.
great pleasure to be here preparing for the 2024 Annual Congress. It's been an absolute delight to come to Bali and mix with my Indonesian colleagues and friends. And I would like to invite you all to come to Bali and enjoy the wonderful hospitality of the Indonesian Neurological Association. We look forward to seeing you here in September of this year.
It's a great pleasure to join the Arab Association of Urology with the Asian Neurological Association together in Bali. It will be a beginning of further collaboration in the future. I invite everyone to join us in Bali 2024 September. Thank you.
I would like to invite you to come to Bali September 2024 and enjoying the beauty of Bali and also the academic atmosphere in UAA 2024 Conference Bali. Come to Bali. See you in Bali.
I welcome you, all of you, to Bali meeting year 2024 this year. This is really an exotic place to welcome all of you here. So I'm waiting here. Please come and join us.